Okay, this little video is just a recording of the talk that I did last week for case discussions on adrenal tumours. We've been lucky enough to have seen three of the main or most common adrenal tumours that you will encounter in veterinary practice, and we've seen them here at Manly Road Veterinary Hospital, albeit some of them have not been definitively diagnosed, but we have strong suspicion that these cases are adrenal or functional adrenal tumours. This is basically just going to be a case discussion, so nothing really formal, but it's just going to talk you through how we've worked up these cases. So before we get into the cases, we're just going to quickly review adrenal gland anatomy and function. We have adrenal glands, which are paired glands that sit close to the kidney, also sit very close to the aorta and the vena cava. The glands are divided into two sections, the cortex and the medulla. The cortex is further divided into three zones. Zona glomerulosa, which is the outermost edge of the cortex that produces mineralocorticoids. Aldosterone is the most important one. The middle is the zona fasciculata, which is producing cortisol. So the one that we measure a lot of is cortisol, which is a corticosteroid. That's what we measure when we're doing ACTH stim, or that's the measurement that we use to check for hypoadrenocorticism. The reticularis is the innermost part of the cortex that produces sex hormones, probably not to the degree that your gonads would produce sex hormones, but the adrenal gland does have some function in production of estrogens and androgens. Now the medulla is, even though it's part of the adrenal gland, so it's part of the endocrine system, the medulla is considered also part of the nervous system, and part of that reason is that chromaffin cells, which are in the medulla, are directly stimulated by the sympathetic nervous system. So the sympathetic nervous system is sends off sort of pre-ganglionic axons and messages. There's no post-ganglionic axons at the adrenal gland, but it's actually the chromaffin cells that will be directly stimulated, and when they are stimulated they will release catecholamines, adrenaline and noradrenaline. Our first case is Toby. Toby Holford is a 13-year-old male desexed Jack Russell. He presented to Manly Road for a sudden onset of polyuria polydipsia. He was urinating a lot outside and not making it to the puppy mats inside. Apart from that, he was generally pretty happy. Clinical examination was unremarkable. His heart rate's about 108, tense abdomen, but nothing else really significant. He was scheduled to have bloods and urine analysis. So the bloods have come back and they show just really mild, non-specific changes there. Red blood cell count's a little bit up, maybe there's some mild hemoconcentration. He has a lymphopenia, which we could attribute to a stress leukogram, and basophils were only slightly up, and I think at that time was not really considered significant. His biochemistry, ALT is high, so twice that upper limit of normal, so considered significant. GGT was also up a little bit, although his ALK Phos was within normal range. Amylase was less than or in the low range, which is not considered significant. His urinalysis, he had a few samples in succession, showing all of them have sort of suboptimal urine specific gravity, trace protein as well. The pH was roughly about 6.5. Now in between some of these collections of urine, sediment was examined, and he did have some cocci noted in his urine. He did have a course of amoxiclav that lasted a couple of weeks. It did not change his PUPD symptoms. Those did not resolve with antibiotic use. Subsequent urine analysis showed no bacteria, so he may have had a silent urinary tract infection. That is significant with this case, as I'll mention as we go along, but the antibiotics didn't actually change his PUPD symptoms. So his problem list: he's polyuric polydipsic, he has an increased ALT, and he has suboptimal USG with trace protein. So differential diagnoses for him would be liver disease, so that could be neoplastic or inflammatory or infectious. Cushing's, I put a question mark in there because the ALK phos is normal. Normally we see ALK phos elevated, but not all the time with Cushing. So you can have a hypoadrenocorticism patient that has normal ALK phos levels. Also, early renal dysfunction is a possibility. We didn't do an SDMA, and remember that azotemia in chronic renal failure, you'd have to get 75% reduction in function for the azotemia to show up on bloods. Diabetes insipidus and psychogenic polydipsia are also potential possibilities, but those are quite rare. So the plan for him was to set up to do an abdominal ultrasound to check liver structure and check his adrenal glands, and also check the structure of the kidneys. So on ultrasound, he had an enlarged right adrenal gland. I don't know if you can see the outline, and I cannot use my mouse to actually show you, but just I'm hoping you can see smack bang in the middle of that picture is a right adrenal mass. Well, that's the right adrenal gland, and it's enlarged. So the findings were that he had a right adrenal mass measuring between 1.6 and 2 centimeters. Left adrenal gland was not found. Liver had rounded edges and was isoechoic to the spleen, which is not normal. Rounded edges on a liver usually indicate hepatic congestion or hepatomegaly. Kidneys had good corticomedullary definition and no pyelectasia, so less likely to be something like a pyelonephritis. So the revised differentials for Toby, he has a cortisol secreting tumour, incidental tumour, or he has primary liver disease. So the revised plan then was to do a low-dose DEX suppression test to check for or to rule in or rule out hypoadrenocorticism. So his low-dose DEX suppression test showed pretty high baseline cortisol, but also quite significantly no suppression at 4 hours or 8 hours. So the differentials, could still be pituitary dependent or an adrenal tumour. He was referred to BVSC. They did do a CT scan of the brain and of his abdomen to check his adrenal glands. He didn't have a pituitary tumour, and they measured with the CT scan that adrenal tumour was actually 3 centimetres, and so the diagnosis was adrenal dependent hypoadrenocorticism. He was started on trilostane treatment prior to surgery, and that's important because hypoadrenocorticism can cause delayed healing. So you want to make sure that you have normal adrenal gland function and therefore normal healing before you go and do quite a risky abdominal surgery. The trilostane was ceased, so he had an adrenalectomy surgery and the trilostane was ceased after surgery. They did note during the surgery, when checking the contralateral adrenal gland was atrophied, and he was started on supplemental prednisolone afterwards at a physiological dose, administered with a sort of tapering dose, waiting for the remaining adrenal gland to start to function properly. His adrenal gland that was excised was sent for histopathology. It came back as an adrenocortical carcinoma with vascular invasion. And it says, while this adrenocortical neoplasm is well differentiated, the presence of unequivocal capsular invasion and extracapsular vascular invasion are definitive criteria of malignancy. Adrenal cortisol secreting tumours can either be adenomas or carcinomas. The larger the tumour, the more likely it is to be a carcinoma. It's 50-50 whether or not you've got an adenoma or an adenocarcinoma. Toby had a low-dose DEX suppression test performed 1 week after he finished his prednisolone dose to make sure that we have adequate adrenal gland function, and he's doing really well. These are his, you can see his last 2 low-dose DEX suppression tests showed adequate control at both 4 and 8 hours post DEX. So that's an example of a cortisol secreting adrenal tumor or adrenal dependent hyperadrenocorticism. I did mention before that he had a urinary tract infection. That's also very common in patients with hyperadrenocorticism. They have silent urinary tract infections because they do have a reduced immune system because of the steroid, and at the same time you won't get inflammation either, so you don't get the symptoms of sort of irritated bladder, those sorts of symptoms. Potentially, Toby's symptoms early on with him missing the puppy mat may have been attributed to a little bit of irritation from a urinary tract infection, but it's a good idea for any of these cases of hyperadrenocorticism to consider doing a culture and sensitivity of the urine just to rule out a silent urinary tract infection. Our next case is Eddie. Eddie is Paula's dog, so we already know what happens to vet nurses' dogs. They always have something weird and wonderful. So we know that this is not going to be something quite simple and easy. So Eddie presented to Minley on a weekend, for a 24-hour history of lethargy and inappetence. He didn't have any gastrointestinal signs, so no vomiting or diarrhea. He did have a history of bilateral cataracts, which were scheduled to be removed with Pauline sometime in the future. He also has a history, each clinical examination that's been performed on Eddie, he has a bradycardia. It's not responsive to atropine. His heart rate's usually around 60, so even when he runs around going crazy, I don't think his heart rate goes higher than 60, and that's actually significant. That's important that you remember what his normal is, because his normal is 60 beats per minute. So on clinical examination, he was quiet, maybe a bit depressed. His heart rate was 128. He had a murmur. His respiratory rate was 28. Temp was 37.6, and he had tachy mucous membranes. His abdomen was not painful. It was quite comfortable, and he had no neck or spinal pain. So his problem list is he's inappetent. He has a tachycardia. He's lethargic. There's also a question about him being a little bit wobbly that morning but prior to presentation. And the other problem is he's got tachy mucous membranes. He was put on IV fluids. He had some bloods run, and chest and abdo rats were performed as well. Remembering a heart rate of 128 in a small dog is not generally tachycardia, but we know that Eddie's normal heart rate is 60, so this is double more than double his normal heart rate. So for him, this is definitely tachycardia. Bloods were boring. He did have low platelets on the machine, but that was checked with a blood smear, and he did have adequate platelets on blood smear. Biochemistry, again, also very, very normal. Nothing abnormal in those bloods. Chest and abdo X-ray. So his abdomen looks okay. There is maybe a question about some in that sort of dorsal lumbar area of his abdomen, just sort of some wispy, kind of similar to fat opacity, and wispy, potentially that looks like it might be retroperitoneal fluid or just basically fat in that region. That's his VD of his abdomen, so pretty normal. Chest x-rays were done as well. So this is a lovely heart, very normal looking lungs. But I also left these in here, even though they're normal. I wanted to show you what perfect positioning we have there with those ribs in that cranial region, very nicely superimposed. So that's very excellent positioning for a chest x-ray, just for note. And just in case you thought that was a fluke, Minley's done exactly the same thing for the right lateral chest as well. Perfect superimposition of those ribs on top of each other, so that's no rotation there. That's really excellent positioning for that chest. But the thorax looks very normal, heart looks normal, and lungs are nice and normal. So as we mentioned before, his chest and abdo rads were unremarkable. He did have some blood pressure measurements taken. So his systolic, went up to 220, and mean arterial at 201, which is really very hypertensive. Your differential diagnoses for hypertension would be stress and pain, but normally you don't get that degree of hypertension. Heart disease can cause that, hypoadrenocorticism can cause hypertension, renal failure, and pheochromocytoma is also on the differential list. So he had an abdominal ultrasound. That video is going to play straight away, but a bit fast. I'm just going to pause it there for a minute. I don't know if you can appreciate, again, right in the middle of this screen here, there is a adrenal tumour. There's a picture of it on the next slide, so I'll just go on. So yeah, there's a kidney to the left. You can see sort of medulla and cortex of that kidney, and to the right of it on the screen is quite a sizable mass sitting there. So abdominal ultrasound that Minley performed, there was a large adrenal tumour on that right adrenal gland. He also had a splenic mass as well. So the differential diagnoses for him would be pheochromocytoma or cortisol secreting tumour, or that could just be a non-secreting or non-functional tumour. So it may be just an incidental finding. He had a low-dose DEX suppression test performed to rule out hyperadrenocorticism as a cause of his hypertension, and he had pretty normal suppression. So he did have an adrenal gland that's suppressed at 4 and 8 hours, so he does not have hyperadrenocorticism. So his likely diagnosis is pheochromocytoma. There are some tests that we could run to definitively diagnose. So there's plasma or urine catecholamine levels. So plasma, catecholamine, I think you have to freeze the plasma or have it collected very quickly after venipuncture. Also, you have to be very careful in trying to collect blood in the least stressful manner as possible, because just the stress of blood collection can increase your catecholamine levels. urine catecholamine collection or urine catecholamine levels, collecting urine is much easier to do, so potentially your owners can do it at home, but there's a little bit more preparation involved in urine collection. So it involves acidifying the urine, so you need to have 3 millimoles per litre of hydrochloric acid, 0.2 mils of that mixed in with 9.8 mils of urine to get it to a pH of between 1.5 and 3.5. And then I think even with that, you have to freeze or keep it in the fridge before the lab collects it. Acid will stop that destruction of catecholamines, because I think they're quite fragile otherwise, but there's a little bit involved in collection. Not impossible. IDEX do perform both plasma and urine catecholamine levels. There's also, I've put there a fine needle aspirate of an adrenal tumour. Can you do that? I think the risks are very high, partly because of the anatomy. You're very close to some major blood vessels, but also because you can accidentally, stimulate a pheochromocytoma to release quite high levels of catecholamines and have a hypertensive crisis. Having said that, Melbourne Uni have done them a couple of times on adrenal tumours that did end up being pheochromocytomas. They actually diagnosed via the FNA. So it can be done. I don't think it's something that we should be doing in general practice, sticking a needle in an adrenal gland. So yeah, you can do it, but recommend not to. So treatment for pheochromocytomas is surgical removal, so that's the treatment of choice, but it is very high risk. Really high risk. Medical management just is aimed at reducing that systemic hypertension and the side effects of that. But note that some patients with pheos can have no symptoms at all, or the symptoms can be intermittent that the owners don't even notice them. Also, another management is to minimize stress as much as possible, so using drugs like trazodone, avoidance of intense exercise. So the drug of choice for systemic hypertension from a pheo is an alpha blocker, so phenoxybenzamine at 0.25 mg per kg every 12 hours. If you, with adrenalectomy for pheo, you must use alpha blockers at least 7 days before considering surgery, and I think the average time is about 21 days. So starting off with alpha blockers, and then prior to surgery, then using beta blockers. You cannot use beta blockers without you need to start with alpha blockers first before you use beta blockers, because using beta blockers can cause irreversible hypertension. So don't use any of your beta blockers for treatment. Alpha blockers are considered adequate for medical management. So that's little Eddie there. Our third case is Bitey Rogers. Bitey's a 14-year-old male D6 domestic short hair. I didn't have any pictures of Bitey because he has since passed. This is a picture of my cat, Buttercup. So Bitey presented to Manly Road for collapse after jumping off his owner's lap. He was floppy, walking around like he was quite drunk. His hind limbs were weak. He is an inside and outside cat, and was perfectly normal prior to this episode. So on clinical examination, he was slightly depressed, a little bit weak, but he had normal proprioception. Heart rate was 230, a little bit high, but might be normal for a cat that's quite stressed and unwell. There was some question about his heart sounds, and I just realized I've spelt auscultate wrong on that slide. It's meant to be or Sculptate, AUS, but anyway, his abdomen is was nice and comfortable. So he was admitted for bloods, chest rads to check the heart, and an AFAST. Blood test showed mild neutrophilia. Platelets were a bit low as well. I'm not sure if they checked with a blood smear with the platelets. His glucose was a little bit high it's likely to be from stress, but the most significant thing on his bloods is his potassium is 2.1, which is very low. So that's quite low and significant, particularly if he's weak. He had a fast done. There was no free fluid, but he did have a possible mass near his kidney. So his problem is he's weak, and that could all be explained by the hypokalemia, just that the way that they've described him sort of being very drunk or sort of ataxic. And the differentials for hypokalemia is gastrointestinal loss. As far as the owner was aware, there was no evidence of vomiting or diarrhea. Renal loss, you can so from chronic renal failure you can have hypokalemia. Hyperaldosteronism, so it's basing, so when fluid moves into the extracellular space, it can take potassium with it. And hyperadrenocorticism, which is rare in the cat. So he was placed on IV fluids to correct the hypokalemia. So he was on Hartmann's with supplemental potassium, and when stable, he was scheduled to have a full abdominal ultrasound just to check for kidneys, check his guts, stomach, and just check for evidence of a tumor. And there was that sort of previous on the AFAS, they had noted a mass near the kidney. Okay, so Bitey, you can see here on this picture there's a kidney which has on the right side there's a kidney, kind of hard to distinguish cortex and medulla on that kidney, but then next to it you can see there's quite a very large tumour in that area close to the right kidney. It's about the same size, so that means it's quite a big one. So that tumour is close to the kidney in the region of the adrenal gland. It was quite large, so 3 to 4 centimetres. There was reduced corticomedullary definition in both kidneys. He had blood pressure checks performed. He was very hypertensive. Systolic of over 190, which is very high. So he's hypertensive, he has an adrenal tumour, and he's hypokalemic. I think it actually took them a long time to replace. I don't think they ever got to comfortably normal levels when he was on IV fluids with supplement potassium. That's a strong suspicion of primary hyperaldosteronism. So how do we diagnose that? Often presumptive, but definitive diagnosis is possible with plasma aldosterone concentration. There are also other tests that you can perform, so aldosterone-renin ratio to check whether it's a primary hyperaldosteronism or secondary. Urine aldosterone-creatinine ratio has also been mentioned as a good test. IDEX only does plasma aldosterone concentrations. From what I've read, you can check plasma aldosterone levels in the same way that you would cortisol with an ACTH stim. So performing an ACTH stim and then I think checking plasma levels, but generally just a once-off plasma aldosterone concentration that's usually adequate for diagnosis. So with Bitey, the owner declined referral for further investigation or surgery. She was not interested in pursuing anything more, so we ended up just medically managing Bitey. Now the treatment of choice for this adrenal tumour is surgical removal if it's a unilateral tumour, and obviously stabilise heart rate and blood pressure prior to surgery. Some cases of hyperaldosteronism can be caused by bilateral hyperplasia or bilateral tumours, and in those cases surgery is not an option. There haven't been very many studies done, but in the one that I've read, about 22% of primary hyperaldosteronism cases have bilateral adrenal gland disease. So it's about a fifth of these patients are not surgical candidates. So medical management involves potassium supplementation, hypocal tablets, which are those large ones which are very difficult to use just because they're so big. A cat would need about 2 to 4 tablets per day to supplement the potassium that they're losing. Spironolactone at 2 to 4 mg per kg for every day. So remember, spironolactone is a potassium sparing diuretic. It is actually an antagonist, or it works at the aldosterone receptor, so it stops aldosterone from being able to hook onto its receptor. And what the mechanism of action of aldosterone is to turn on the potassium sodium pump in the distal convoluted tubules in the kidney. So what would happen if we had too much aldosterone would be that sodium and potassium gets switched. So potassium would move into the distal convoluted tubules, into the urine, and then be lost in exchange for sodium. And so if spironolactone is acting at the at the aldosterone receptor, then aldosterone is not able to function. So it is sort of a competitive inhibitor at that receptor. Also, treatment is amlodipine for that hypertension, so anywhere from sort of an eighth to a quarter, I think, of a Norvasc tablet for a cat every 24 hours. So Bidey did live a pretty uneventful life until he developed a bleeding nasal tumour. I don't know if the excess bleeding was related to his hypertension. There definitely was a nasal or a mass in his nose. I think it was actually visible, and he was euthanized 4 months after that sort of initial diagnosis. The next slide is just a quick rundown of the tumours that we've discussed. I'll try and save this or on S Drive or something, so it's easy access, but basically it just goes through all the 3 different types of adrenal tumours and how you can actually diagnose them, and some of the pathognomonic or the most common signs that you would see. Actually, nothing's really pathognomonic here with your full body function. Even hypertension is seen in all 3 of these tumours. So that's it.